And so it was excellent 2 talks by our imagologist, the radiologist and nuclear medicine specialist. So I will talk about the general aspects about evaluating a patient with spinal metastasis. I'll also cover non-spinal metastasis, bone metastasis, and I will also share some of the things which are not necessarily, they don't have evidence for that or data on, but which I've seen in the clinics. A lot of people make mistakes. I myself used to make those mistakes, but over a period of years, I know that's an area for improvement. So this is a picture that you see. This is a spinal metastasis. So this spinal metastasis is actually of this gentleman. I'm sure all of you can identify who this gentleman is. It's a mummy. So he struggled with a long, painful, progressive illness. When he succumbed to the mysterious ailment, his family got him mummified. That was more than 2,000 years ago, so that he could, be reborn and have the pleasures of the afterworld. So this was an Egyptian mummy. Incidentally, his name was also M1. They give some name, and he died of a M1 prostate cancer. So this, if you look at it, some of the things which I have, not underlined, anyone with the metastatic cancer, except for certain metastatic cancer like germ cell tumors or some other this thing, they would have a long and progressive illness. Sometimes it's a very short illness, but they need not be painful. And it need not be a painful struggle or mummification. Sometimes with our treatment, we actually mummify them. And everyone after the treatment of metastatic disease, they are reborn, but they do not relish the life after the metastatic disease. And I think what we can do in this careful evaluation of the patient, holistic evaluation plays a very important role, that they have an afterlife after the metastatic disease, and it is not a struggle for them. And wise decision making for therapeutic goals, deciding the modalities and sequence and skillful treatment. What I have pointed in red, modalities and sequence and skillful treatment, majority of the discussion, even in forums or for a patient, is based on what things we should treat and how well we should treat. But there are so many other things which are not covered in the. So this, you see, Rudyard Kipling, we know, he wrote a book called The Children of Zodiac. So in that he had many characters, and one of the characters was crab. And when he describes this crab was actually used as simply for cancer, and crab killed one of the male leading characters. So cancer, the crab lies so still that you might think he was asleep if you did not see the ceaseless play and winnowing motion of the feathery branches round his mouth. That movement never ceases. It is like the eating of a smothered fire into rotten timber, in that it is noiseless and without haste. So why I've chosen this about this thing, I had used this quotation for my thesis on MD thesis, which was 30 years ago on bone metastasis, is that you might think he was asleep and the movement never ceases. So when to anticipate trouble from currently asymptomatic metastasis, and that you have to know about this crab, which is the cancer. And the other is that, like if you have a team of firefighters, imagine we are like firefighters, we give them, bisphosphonates, we give them radiotherapy, we do vertebroplasty, and after that we feel that everything is done. So it is eating of a smothered fire into rotten timber. So even after the team has done its best to smother the fire, the rotten burning timber, which is the osteoporotic bone and diseased bone, may continue to trouble, and re-evaluation of these patients is very important. It is actually sometimes more important follow-up of these patients and skillful re-evaluation than at baseline, that things are more straightforward. The treatment algorithm is more sort of straightforward. I'll just very briefly tell about a study which we are doing right now, which is a prospective cohort study of breast cancer patients with new bone. Sorry, I forgot to write the number of cases. It is around 250 cases now. To look at new bone metastasis to estimate the quality of life, health economics, and risk of skeletal complication. And that's the main thing, because we want to estimate the key skeletal related complication and prevent them, hopefully. And of course, also look at pain and factors which will predict that they would live either very short or a long, so that we can decide how aggressive we should be in the management. So this is for breast cancer. The interim analysis of first 143 cases for my MD student, Dr. Asma, when they had a follow-up of 17 months, minimum 6 months. So bone metastasis at initial diagnosis, it was in 39%. In other patients of breast cancer, it was diagnosed, bone mets were diagnosed during follow-up. Spine, if you look at it, 80% of the patients had metastasis in the spine. And there were only 20% patients where the bone metastasis did not involve the spine. Majority of the patients had pain score of 4 or more on a scale of 10. That means they are symptomatic. Radiotherapy, 60% patients required radiotherapy when they were diagnosed with bone metastasis, 15% later, and 25% have not yet required radiotherapy, but many of them are likely to require radiation later. And the skeletal related complication, the whole purpose of in a prospective cohort was seen in 26% cases and cord compression in 15% cases. If you try to think, you don't think that so many patients have, but in a prospective cohort, you see this. So the evaluation of bone mets does not start with and does not end with the first 2 lectures we heard. And that's how, why I've written this, because, it's just the scans, the bone scan, the PET scan, the MRI scan, and of course, X-rays also have some role now, though not as much. This is just one of the part of the overall evaluation, but I think this hogs the limelight of not just in discussions in the clinical meetings, but also when you're talking of the patient management. So evaluating the patient's and symptoms, signs and imaging, you have to evaluate it, getting it right to set appropriate therapeutic and rehabilitation goals. And I think important is not just treatment goals, but also rehab goals. And unless until your evaluation is not full and proper and comprehensive and holistic, it is impossible to set a goal which is appropriate for that patient which you will be pleased and as well as the patient will be pleased. As treating doctors, sometimes we are pleased when the scan looks good. I tell them don't treat the scan, but I also do that. We all treat the scan. We have to use the scan to treat the patient, not treat the scan. So first and foremost, is it a metastasis and not one of the several other things that may mimic a met? I think both the previous radiologists talked about that. I won't talk about this. What symptoms are attributable to the spinal metastasis? So every symptom that is there is not because you have seen something on that. There are other things which give rise to symptoms. How we clinical and neurological signs that are associated with the spinal mets, ordering the right imaging and interpreting in the clinical and neurological context. So sometimes in our country and in many places, the radiologist will do the scan, whatever the clinician asks. In some countries, radiologists will call you back and say, no, this is not the right. So it is a clinician's duty to know what imaging to order and when to order, because it's a long history. When a biopsy confirmation is required, when to look beyond bones, cords and nerves, and what is the expectation of clinical benefit, not just of the doctors, but everyone else. And based on this, set the therapeutic goals that are feasible and mutually agreed by the patient, the doctors, the rehab team. And I will also like to invoke the caregivers, because in one of the studies we have shown in this bone metastasis through our CONQUER study only, that the caregivers also go through a lot and their quality of life takes a dip. And then deciding therapy. So bone metastasis in their various clinical contexts, the primary site is identified and is known to be associated with bone mets, like say breast cancer, lung cancer, thyroid cancer, kidney cancer, prostate cancer, or occasionally from an unknown primary or a primary which is not known or not commonly known to give rise to bone metastasis. So it could be asymptomatic bone mets detected incidentally during staging workup, or it could be a symptomatic bone mets at the time of cancer diagnosis and follow-up. Earlier, when I was a trainee, most patients had symptomatic bone mets, but now the pendulum is shifting more and more. We are finding patients with asymptomatic bone mets, and it is part of the widely disseminated, cancer, or it is just solitary of few bone mets and no other visceral mets, what we call OMBC. Earlier, we used to just call it solitary mets, now we call it OMBC. So in each different setting, the evaluation has to have a different thing. So like if a patient is part of a widely disseminated cancer and symptomatic bone mets, I think the evaluation part is more about that we treat the right part. But if it is an asymptomatic bone mets or it's solitary, then I think we have to have all the knowledge and skills in evaluation. So first and foremost, is it a metastasis and not some of the other things? So this issue is worth pondering and pursuing only in some cases with solitary and few bone mets, and where the M status will change the multidisciplinary management. Sometimes the M status will not change. and the optimal imaging has not been done or not possible. What was shown that they have done all the imaging, that was one case. That was a case that you show. But in some patient it is either not done or it is not possible, and some patients have contraindication for MRI. And is it, you have to see it's a chronic pain with or without acute exacerbation, or a poor bone health or osteoporosis. Whenever you have these things, you have to be extra careful that there may be other things which can be contributing to this, and it may not be a metastasis. And the scan finding, as previous speaker showed, cannot always distinguish. And they may have spine conditions like kyphos scoliosis, they may have trauma, they may have inflammatory, autoimmune, metabolic bone, joint or disc diseases. And all these do exist. I mean, most orthopedicians have a flourishing practice, not just by treating trauma, because all these conditions they do. If you sit in a spine clinic, you will see that only few are metastases, and it is full of such cases. Patient may have altered gait or unequal weight bearing due to non-malignant causes, and so on and so forth. And the list is endless. So why I'm showing this picture, this patient was, can we minimize this? Just one second. Okay, so this patient came with a pain in the left hip. Bone scan showed increased uptake, and X-ray had a sclerotic mets in Tata Hospital. It was about 7 years ago, and we referred this patient for palliative radiotherapy to a medical college in West Bengal, Bankura Medical College, and started her on zoledronic acid. Fortunately, the radiation oncologist there in Bankura Medical College, was reluctant, and she returned to us. And then this is another view of the same scan. People showed only the other scan. I'm talking of X-rays. And then she fetched her old X-ray 20-year-old ago. And it was evident that this was not a metastasis. And she made a great escape from the M1, or what we would have now called ONBC diagnosis and its treatment. Cancer treatment, especially now when you give high dose of radiation, you give years of bisphosphonate, can have toxicity. If I would have treated her, she might have had, hip avascular necrosis of the hip and so many other things. Already a diseased hip, by giving tons of grays of radiation and other thing, I may have actually harmed her. So she had a lucky escape thanks to a radiation oncologist whom I don't even know, in a small medical college. I may not be small, I'm sorry, but in a medical college about which I'm not aware. Another condition, look at this. So this is again, you can see all these bones. So anything which looks hot on a bone scan does not mean metastasis. Some people don't look at X-ray, only look at the bone scan report. And even the radiologists sometimes get it right. They are not gods. So you have to remember. Finally, the person who treats is that person's responsibility. So what symptoms are attributable to the spinal met? So the asymptomatic cases with missed or every patient whom we call asymptomatic, sometimes when you listen to them, you realize they actually had some symptom, or the symptom what you called was misattributed to something else. So pain location, again, I don't have to talk about this. Everyone talks about the bone pain, neuropathic pain, but also look at the joint pain, myalgia. Sometimes it is a myalgia. And many times these patients have a visceral pain and a mixed pain. So some of them who have disseminated disease, a patient may have pain, you might think it is because of rib or the costovertebral junction mets, but it is a large, liver metastasis which is causing the pain. So that is very important. So you will not palliate that patient just by giving radiation. Severity of pain, and use surrogate markers of pain. And what I find very useful, if a patient who hasn't slept for a few nights is in severe pain, irrespective of that, whatever she points on the VS scale. Chronic pain, you have to be very wary that patient has a long history of pain, especially low backache, hip pain, shoulder pain, frozen shoulders, and these things are not so uncommon. So relieving an aggravating factor, sometimes I want to correlate which pain is coming from where. So why I am saying this, because if the bone lesion which is causing the pain, if that has been given radiation, anything 6 gray and above, there should be a pain relief. If a patient has no pain relief after the initial flare, it is a clear-cut case of geographical miss or something else. A mechanical factor has set in and caused a microfracture or something else. So there is no third reason other than this. So correlating which is the cause. Then altered sensations, they are typical and common. Sometimes they are atypical or rare, like saddle anesthesia, motor weakness, should not compare with generalized weakness or generalized weakness with wasting, balance in gait, and of course bladder bowel. So in clinical and neurological science of spinal meds, see them, that's very important. The moment the door opens, see them walk in or wheeled in, how they're sitting on that, the face, the gait, and when they are getting on the couch, the posture, stiff back or neck, loss of lordosis, how they get on the couch, and then very systematic musculoskeletal evaluation. If you remember when we had our ortho postings, they used to teach us how to do a systematic musculoskeletal evaluation. Patient with bone meds, this is very important. One point I would say, muscle spasms are quite common. And if you are treating a muscle spasm with radiation and because something else, that will not be relieved. Eliciting tenderness, there are rules and care. I think this is more of bedside teaching, but there's a way how you elicit tenderness. And one thing I would say, many residents pay so much attention to tenderness, but I think tenderness is just one point. Ordering the right investigation, I won't go into this. Just one point, I would say that at baseline, often we get a comprehensive evaluation, a battery, but deciding what is enough for this patient is an art. And during follow-up, every time there's an exacerbation of existing symptom or a new one, we don't repeat them all. So you should know, not just X-ray, which region. I think that's where clinical evaluation is very important. You have done X-ray of the wrong region. And MRI again, for bone scan, PET scan, everything is covered. But MRI, when and for which region, I think that's the clinician's responsibility. So we have already said when to do a biopsy, when in doubt. So analgesic use, it's again very important part of assessment. Detailed history of not just what drugs, dose, drug chart, diary, side effects, use of adjuvants, and many other methods that they use. So there's a tiger balm, which is very common. There's so many other things. When the patient walks in, you can smell it. And there are many other methods and also other medication and drug-drug interaction. So risk of skeletal complication, we rely mostly on imaging. Imaging is just one small part. I think symptoms are very severe. If patient has a severe acute exacerbation of pain or gets a very severe pain, like a devil's grip, you have to expect there may be a complication. So Merrill score was popular, but I think its relevance is being questioned. I will skip this. So this is a spot diagnosis. People will say bone meds. I'm showing is, I took a lecture of oncologists, 50 trainees. None of them said this is a trauma. You can see clear-cut linear multiple ribs. And solitary rib metastasis, very often this will fox you. And there was a study I was happy to see, it was published, 324 rib lesions, and then 324 breast cancer patients with rib lesion. When it was a solitary rib lesion, more often than not, it was non-metastatic. This is a very old picture people do not know, but doctors who are trained in the PET, CT and MRI era, we often struggle to read skeletal X-ray. Sometimes all this winking owl sign is, that's all you need, the pedicle is destroyed. So looking into beyond cord, so I think this is very important when you want to have a holistic assessment, where they live, how they will travel, social factors which may predispose to pathological fracture, personal fractures, and how pain and disability will affect their own as well as the caregivers' activities of daily living. So I think this is an integral part of holistic assessment. Sometimes in our busy clinics we miss this. Then patients and physicians' expectation of clinical benefit with spinal meds management. So of course, degree and durability of pain relief is there. Reduced need for long-term analgesic use, preventing or relieving clinical cord compression. Not just better MRI pics and have a mutual admiration society, all of us pat our backs. Maintaining or restoring maximum independence in activities of daily living, restoring health and functionality to allow other interventions that are indicated in control extraskeletal disease. Sometimes we get so obsessed by treating that bone meds with SBRT or whichever method that we forget that there are other parts of the disease which needs to be managed too. So setting therapeutic goals includes all. And patients and their primary caregivers have the largest stake in setting therapeutic goals they think are appropriate for them, and due consideration should be given to them. And why I'm writing this statement, which is obvious, is because many times in clinical practice, they are not given that due consideration. And the goals may not be confined, not merely living longer and with less pain, but should be more holistic, more realistic, function specific, and major life event specific. Some patients have this, I have this function to attend, whatever else. And I am not surprised now, but when I was a younger doctor, I would not have believed that the rehab team and nurses are far more in tune with the patient's goal and wishes than the medical treatment team of oncologists and spine surgeons. So I think I'll just finish this. Okay, so this is my last slide. Skillful and comprehensive patient evaluation at baseline and follow-up allows a medical rehab team to set and achieve mutually agreed therapeutic goals. You have to choose wisely. Choose a mutually agreed therapeutic goal. Choosing for a mutually agreed rehab goal may be different. Use the least invasive modality which could achieve these goals, and multimodality approach often needed. Its timing and sequence has to be right for that patient. Thank you.